Hi everyone, welcome to Women Empowerment Shattering Session. We hope that you will enjoy today's session with Dr. Sunaina, who will be discussing about pediatric. Thank you, Dr. Sunaina, for joining us today. Whenever you feel ready, please begin your presentation.
Great. Hi, everyone. Thanks for joining us today. So I'm a pediatrician and I wanted to introduce you to the field of pediatrics. So my overview, I'm going to kind of go over who I am, my journey here, the demographics within the pediatric field, how you get to the path of pediatrics, what my daily schedule looks like now that I'm here, what I do, what pediatricians all over the country do, interesting cases kind of related to a variety of aspects of the field, and then I'll open it up to some questions or discussion as well. All right, so I graduated from Austin College in 2011. I got my Bachelor of Arts there. I majored in biochemistry, but I minored in communications. And after that, I went directly to the College of Medicine at Texas A&M, and then I graduated there and went to Oklahoma University, where in Tulsa, where I did my pediatric residency. And so after residency, I moved back to Austin, which is where I went to medical school, and now I'm working at a clinic there. You can follow me and my journey on Instagram if you'd like to, at East Austin Pediatrics. All right, so the demographics of the pediatric field. So this is one of the fields that is more skewed towards women in general. So you'll notice that the green is women and the red is male identifying individuals who have gone into this field. And you can see that it is majority women, all pediatricians to residents to primary care. And then when we get to subspecialty, there is a lower proportion of women, but we still are the majority there. But even though women make up the majority of pediatricians in general, when we're talking about leadership roles, you still see that there's a huge disparity in who is choosing to join those leadership roles. More often than not, you're going to see that women are going to not be in those higher roles in the pediatric field itself, even though we make up the majority of pediatricians. And then this is another chart that's showing you, even on the boards in which we serve and are the majority, the president of those boards and directors, even within the AAP, the American Academy of Pediatrics, are mostly men. So you can see, on that, in that middle row there, the women N of N percentage, we make up 50 to 60% of the boards and representatives and councils within the AAP. But when you look at the president equivalent of those same groups, most of them are men. And then I wanted to get into other demographics as well. So in terms of age, you can see that it does tend to skew younger in the pediatric field. So you are going to see more pediatricians who are under 39 years of age. But it's still pretty even, especially when you get to all pediatricians in general. There's a good variety of age groups there. And then when we talk about racial and ethnic distribution, you can see that it is still majority white. There is some representation of the Asian subgroup, as well as Latino, Hispanic, and some Black, but not a lot. And then when we talk about, the way that pediatricians decide to work, a lot of them actually do work part-time. So 21% of all pediatricians are working part-time. And usually it's because they have another job that they're in, or they want to make space for family time. And you will notice that most of those who are working part-time are actually female. And then average hours worked per week. I think it's always good to know how much our pediatricians working. And it's somewhere between 40 and 50 hours a week, which isn't too bad. When you look at other subspecialties and other fields, a lot of them work a lot more hours than that. And within that, a lot of that is direct patient care, but you'll notice that administrative duties, academic duties, research are all parts of the work week as well. So when we talk about our path to pediatrics, everybody goes to college. They have to graduate college, and there are pre-medical courses. Those course requirements vary from school to school and hours as well. And you don't have to actually major in the sciences in order to apply to medical school or even to be a strong candidate for medical school. So as long as you have those pre-med course requirements, it doesn't really matter what your major or your minor is. You take the MCAT, then you go to medical school. After medical school in the United States, there's residency, and for pediatrics, that's 3 years long. And then we go to fellowship for 1 to 3 years after that. And so, when we're talking about, the female experience within pediatrics, you'll notice that, women are more comfortable in the pediatric field. I felt like I thought it was a much more supportive environment for people in general, especially people with families, which is great. But then when you get into the fellowship and subspecialties, you're going to notice that there was a lower proportion of women to men in that. And I think it just goes to show that, that training course where you have to be training for longer periods of time, it becomes harder and harder. And even for women who are going into this field and are being well supported, for some reason, they're having a hard time being supported throughout their fellowship as well. But what is our daily schedule like? So everybody's schedule is different. I am an outpatient pediatrician. So that means that my schedule is a usual 8 to 5 schedule where I have a morning shift, I have an hour break for lunch, and then I have an afternoon shift. Now, my clinic schedule is pretty cushy, but there are some that, they get there at 7 a.m. They don't leave till 7 p.m. So it all depends on where you choose to work, what kind of lifestyle you want to have. Our clinic also has after hours. I think it's especially important in pediatrics to be part of an organization where, parents who are working have access to care in the evenings. And so our after hours are open from 5 to 9 p.m. on the weeknights and 8 to 5 on the weekends. And we all take turns doing that as well. So that's more hours there. So some people have just a normal 8 to 5 where they don't have any other responsibilities, but you are kind of limiting access to families who need it. And other clinics have a broader variety of clinic hours like ours does. So I work 2 nights a month as well as 1 weekend day a month, which means that there are 2 nights a week that I work till 9 p.m. and there's 1 weekend day that I work 8 to 5. And those weeks are 6 days instead of the usual 5 days, which isn't too bad. And then we also round in the newborn nursery. So pediatricians not only take care of kids who are outside of the hospital, but they do take care of kids who are in the hospital as well. And even the doctors who work outside the hospital can be working inside of a hospital, depending on where you're located. So in my city, we do the nursery. So whenever a baby is born, we'll examine them in specific hospitals if we're on call. And that's added on to our clinic schedule. So you have to get up earlier those weeks and that kind of thing. And then one night every season or so, we'll have overnight call where in the newborn nursery, if a baby is born after hours and there's a question, they'll call us to ask us how to take care of that child. Now, in smaller, more rural areas, you might have even more responsibilities than this. Some pediatricians in rural areas even see their older kids who are admitted to the hospital. So if you had a child with pneumonia who was dehydrated or needed IV antibiotics and you admitted them to the hospital, instead of having a hospital doctor who oversaw their care, you might be in charge of them, including all of the patients that you're seeing outpatient as well. So you would round in the hospital, see that patient, and then you would go to work at your clinic and potentially have calls all day on that patient as well. So it just kind of depends on where you are and how you work and what kind of lifestyle you want to have, what is important to you in terms of your personal life, but also the things that you like to do at work, what your schedule might look like. So what do pediatricians do? They can do a lot of things. Anything related to the care of a child is incorporated into pediatric work. So babies who are newly born, who are 0 years old, 0 days old, all the way up to age 21 and sometimes even age 25, pediatricians can care for. So we attend deliveries. So if there's a high risk delivery, you might see a pediatrician there trying to take care and resuscitate the baby. We work in hospitals. So oncologists, kids who are admitted for cancer, kids who are admitted for broken bones, they might see a pediatrician in the hospital as well. And then we follow healthy kids in the clinic. So when you are going to your Annual checkups at your pediatrician's office. We did that too. The same doctor could do all of those things. We work in emergency rooms, we work in urgent cares, and then every subspecialty that you could imagine in adult doctors' worlds are also in the pediatric realm. So things like I had mentioned oncology, gastroenterology or stomach issues, neurology, so kids who have seizures or mental health disorders. What else? Infectious diseases, pulmonology or lung support, cardiology, heart doctors, all of those things that you might see, an adult might see a doctor for, a pediatrician could subspecialize in as well. Another big part of pediatric work is public health and health equity. So not only are we just doing the medical work, but there's a lot of political aspects to healthcare that pediatricians are involved in as well. In the United States, we have organizations for all the different types of doctors. So American Academy of Pediatrics is the one that pediatricians have formed, and we pay funds that actually help our organization fight for health equity and the rights of children at the federal level. So we have every year in Washington, D.C., a forum where we go and we discuss our specific topics of discussion. For example, guns in schools is something that the AAP talks about. Child abuse is something that the AAP talks about. Access to affordable groceries is something that the AAP talks about. Informed consent for children, which is called assent, is something that the AAP advocates for. So these are things that you might not realize that pediatricians are involved in the political realm, but they are. Also, we advocate for the prevention of chronic diseases. So a big part of why I joined pediatrics was because I feel like so much of our healthcare system is a sick care system where we're trying to solve problems. And in pediatrics, we're really trying to prevent those problems. And so talking about how do we control weight in childhood, a lot of those factors are genetic that we can't control. And a lot of those factors have to do with our public health policies and our political policies. How do we affect change at that level as well to help control weight? And then advocating for social justice. So here are some cases that I wanted to kind of go through with you guys. So this is a baby girl that you are being called to the delivery for. She's born on time, so 38 weeks gestational age is a term delivery, and her mom had her vaginally. But when she was born, she was blue and she's not crying, she's not making any noise. You can't tell if she's breathing, and she's limp. So very, very scary thing. And you have to know what to do. What do you do in this situation? So, in adults, usually if you see someone who is blue and limp and, not responding, your first guess would be that you would do CPR, where you actually perform chest compressions. But in newborns, that's actually not true. So her oxygen saturation is 60%, which would be very, very low for an adult person. But in a newborn, you can see on this graph here, at one age of life, that could be a normal oxygenation range, 60 to 65%. Her heart rate, though, is 80 beats per minute, which an adult would be normal. But in her case, a heart rate below 100 is actually abnormal. So this is the newborn resuscitation flow sheet there that I have listed here. And it's a little bit old. It's 2010. There's a newer one, but this is the one that I could find to put on my presentation. And it's actually very different than the way that you would resuscitate an older infant or a child or an adult. So pediatricians have to know how to resuscitate a wide variety of kids in a wide variety of situations. So in this case, all we have to do is make sure that she's warm, stimulate her as best as we can, dry her, suction anything out of her airway that might be causing her to have some trouble breathing. And if she's still not breathing well, then before we even do chest compressions, we actually give her oxygen. It's different from the way that you would deal with an adult. And usually at that point, they kind of perk up and they do fine without ever having to do chest compressions. Let's say you're still in the newborn ward and now you go in, your nurse is asking you to see this newborn that they want to discharge today and go home. And you walk into that room, everything looks good on their chart, and you're going to tell them that they can go home. And this is what you see. You see the birthing parent sleeping with the baby like this in their hospital bed. Well, in kids, in infants under the age of 1, co-sleeping is actually very dangerous. It increases their risk of sudden infant death syndrome. And so when you see this, it's actually our responsibility to talk to parents about the risks associated with this. This parent and this child actually look very comfortable, and the baby seems very safe, but it can be a very dangerous situation. A parent can roll over on the baby, or for whatever reason, the baby can stop breathing and we'll never know why. There could be something that falls on the baby, like a blanket or a pillow, that could prevent them from breathing. And sometimes in sudden infant death syndrome, we don't have a reason for the baby to stop breathing. It could be something related to their brainstem that regulates our breathing that was abnormal in them and we never knew because you couldn't tell from their exam and things like that. So counseling families on ways to mitigate that risk is an important part of sending a child home, letting them know the things to look for, the things to take care of at home that aren't even a problem yet, to prevent accidents from happening. Now you are seeing this baby who's 9 months old, and they have this rash all over their body. And mom is so worried because they feel like something is really wrong, and the daycare is not letting them back in because they think that this rash is contagious. And so you examine this little boy, and this is the rash that you see, which is all over his body. It looks like it could be so painful or so itchy. And it looks pretty kind of freaky to the parent seeing this rash for the first time. But you know exactly what it is. And the kid is sitting there so happy, playful, laughing, interacting with you just fine. Doesn't even seem like they have a rash on their body. So you ask this parent, you say, hey, has he had a cold recently? And they say, you know what? He did have a really high fever 4 or 5 days ago, and we didn't know why. And it just went away. So we didn't think about it. But now I'm really worried that fever means that something is super wrong because of this rash. And it's actually something called roseola. Roseola is a viral rash, and kids get viral rashes all the time. So now your job is to explain to mom that this very scary looking rash is going to go away on its own without any medicine or anything to do, and that the child is totally fine. And even though they have this horrible rash, or a rash that looks horrible, even though it's not really that bad, they're not contagious at all, and they can go back to daycare. And this is something that is sometimes very hard for parents to accept because this rash looks so concerning and is so red and so irritated looking, and they're totally fine. Now you might have a wellness visit with a little girl who's 6 months old, and you notice that their head is growing a little bit faster than you would expect. So every time a child comes in for routine health visits, especially under the age of 3, you check their head circumference, their length, and their weight, and you just monitor them for any growth changes. And so this is the head circumference age percentiles. So we chart everybody's head on these charts up to age 36 months, and we try to come up with a percentile. And these lines here kind of represent kids who are at varying ranges of percentiles of head circumference. And each kid should follow the same percentile every time they come in. So this child, for example, that really dark black line is where they tracked the first 3 times we saw them. And that dark black line is the 50th percentile. So you would expect them to be in the 50th percentile when they come in for their 6-month visit. But now you're noticing they're actually on the 75th percentile, which is a little bit higher than you would expect. So what do you do in that situation? Why is their head growing faster? Well, first you recheck it, because sometimes when you check it the first time, you weren't very accurate, or the baby was wiggling and it was hard to figure it out. So you recheck it and you see that it is still that same exact number. And then you have to kind of explain to mom all the different things it could be. So sometimes babies' heads just grow bigger all of a sudden for no reason. That's totally possible. Our bones in our skull are not fully fused. So it is entirely possible that, they could continue to grow or grow a little faster than normal. Sometimes there are ventricles inside of our brain, or little chambers that help the cerebrospinal fluid kind of flow through. And sometimes there's a blockage in between those chambers, those ventricles. And that could mean that there's fluid building up in our brain. We call that hydrocephalus. And it could make our head cavity bigger because there's more fluid inside. If that's the case, then they might need to see a neurologist or a neurosurgeon to fix that problem. So it's important for us to find it out sooner than later, because the pressure on their brain could prevent them from developing normally. Or there could be something else going on. So you get a head ultrasound, and the head ultrasound shows that there is some fluid in their inside their skull, but it's not cerebrospinal fluid. It's actually blood, and that is a huge concern. Why would there be blood there? So you get an eye exam and you see this, and these are what we call hemorrhages, and the little arrows are pointing to those hemorrhages there. And these you only ever see if someone is actually being abused. So now you have to talk to mom about someone could be hurting her child. It might be mom. It might be someone at daycare. It might be dad or boyfriend or someone else in the family who's taking care of this child. And it becomes a social issue, right? You have to, a legal issue. You have to talk to the police, and you have to, it becomes an investigation. And that's something that you might see as a pediatrician too. So you have to counsel mom on all the different things it could be, and also make sure that you keep the baby safe, and also make sure that you treat the baby. So lots of things that pediatricians deal with. And then this is a 7-year-old who came in for their wellness visit, and you're asking them how school is going, and it turns out that this boy's not doing that good in reading. So a lot of parents don't realize that if their child isn't doing well in school, it's something that a pediatrician could help with. Having trouble with reading could be a behavioral issue because they're being bullied at school and mom didn't know because he hasn't talked about it. Or it could be because of ADHD and the child can't focus. Or it could be because of dyslexia. Or it could be that there's some sort of foundational issue. And so often we end up counseling parents on different ways to get their child resources that we might not directly help with, but can definitely connect them to. So things such as an IEP or an individualized education plan, where we advocate for the child to have special time with their teacher, special resources or extra time, or kind of different expectations so that we can get them back on track. Or we send them to a psychologist who can evaluate them for different ways that their brains might work differently that could be causing them to have trouble with reading. And you have to counsel them in a routine wellness visit while you're also talking about all the other million things that we talk about, including height and weight, including are they brushing their teeth twice a day, including are they going to the dentist, including safety at home. So, do we have helmets when we ride our bicycle? Are we wearing seatbelts in the car? Do we have carbon monoxide detectors at home and fire alarms? And have we changed the battery in the fire alarms? Is anyone at home smoking? We have to talk about tuberculosis exposure and lead exposure and all kinds of things, puberty and things like that, that all of those things we have to incorporate in one visit and to make sure that a child is growing and developing normally and staying safe. And then you see the 16-year-old who comes in for a sore throat, but they also have cough and they also have congestion. And the caregiver who comes in, they want a strep test, and they say that every time they come in, they always get a strep test. The other doctors in your clinic order a strep test. How come you're not ordering a strep test for this sore throat? Well, with sore throat, we know that it's very unlikely for them to have so much cough and congestion at 16 years of age. Usually when you have strep throat, you only have that sore throat. Sometimes you have a headache and a stomach ache and some nausea, but not usually so much coughing. So if coughing is happening, you already know it's not strep. You don't need a test to prove that because you went to medical school to tell people that they don't have strep. So what do you do? Well, in this case, you have to counsel and educate them and say, hey, I know that somebody else does it differently, but this is the way that I do it. And this is the evidence behind why I'm doing it that way. But then you also have to figure out, how do I prevent this from being the expectation the next time a child comes in? How do I talk to the other physicians in my group so that we can make sure that we're not ordering strep tests on everyone when they don't need it? A strep test is $100 every time you order it. If you see 20 kids a day with sore throat or cough or congestion, and you're running, a strep test on all of them, that's $2,000 a day you're spending on kids who might not have strep. And you could have easily diagnosed them without spending that money. So that's another part of being a clinician, is trying to figure out how to be evidence-based and cost-effective and fair to your patients. So now you come up with a quality improvement research study. A quality improvement study is where you find a problem, you try to come up with a solution, and you see how that solution works. Does it fix the problem? And if it doesn't, then you come up with a new step to kind of fix the problem. So in this case, you might say, hey, what I'm going to do is I'm going to set up a presentation on strep pharyngitis, and I am going to discuss with my colleagues at lunchtime one day or at one of our meetings the different reasons that you would order a strep test and the reasons that would contraindicate ordering a strep test. And maybe just the education, that educational aspect would be enough. And then you would see what happens for the next month. Did the number of strep tests go down, or has it been exactly the same? And if it's been exactly the same, then you say, hey, I need a new solution. Maybe it's not just that they don't know, maybe there's another way that we can change this. So that might mean every time somebody orders a strep test, a little box pops up that says, hey, you're ordering a strep test. If this person has a cough, they might not need that. Are you sure you want to order it? And then they have to say yes or no. And see if that changes it. And then you kind of continue to do that until you figure out how to improve this problem. That's part of a job. Even people who are working in a private clinic do research studies like this. And then there are administrative things. So for example, in January this year, we have a new coding system. So every time a kid comes in and we see them and we order tests or we prescribe medications, or maybe we don't do any of that, we have to tell insurance companies how much they're supposed to pay us for the work that we did. And it's based on what we did, how long we spent with the child, what we ordered, all of the different things. So they changed how we tell them those things. And when you realize at the end of this month that you've actually made less money than you did January of last year, and why is that? What was it that we're doing differently this year with our new coding system that we could be changing? And so having to go through the administrative aspects of your electronic medical record and how reimbursement works is another thing that happens either in the private or even in the educational or academic settings. Alrighty, so those were my cases and everything. Does anybody have any questions?
We do have some questions on the YouTube chat box. So the first question we have is, what is the most challenging situation you came across in pediatrics?
The most challenging situation I've come across in pediatrics. So I think the most challenging situations are when you have a medical problem that has a stigma related to it. So for example, mental health is a big one. The mental health is brain health. And sometimes our brains work differently, and that's not in our control, but there's a lot of stigma around mental health and mental health care. And so figuring out a way to broach that topic when a child comes in for things like they're not doing well in school, but really the issue is not school, is that they're depressed, or they're having a lot of angry outbursts and fighting at home with mom, but it's not because mom is being aggressive or anything like that. It's because they actually don't feel good. They have anxiety. So that would be my number one most challenging.
If not pediatrics, which field would you go into?
If I hadn't chosen pediatrics, I probably would have went into psychiatry. I think that a lot of the reason that I joined the medical field was in order to advocate for people and to serve them in a way that has the greatest amount of need. And in my opinion, that is psychiatric medicine as well as obstetrics and gynecology, women's health. There are huge health disparities in those three fields. And so figuring out ways that we could solve those problems would be kind of my passion in life. And so those would be the fields that I would go into.
And as a follow-up to this question, how did you know exactly that this is the field you want to be into?
That's a great question. So in pediatrics, you actually get to rotate in medical school through all the different specialties. So you get to go through family medicine, you get to go through surgery, obstetrics and gynecology, internal medicine, and pediatrics and psychiatry. So You get to see a lot of different fields, and even within those, you get to see some of the subspecialties you might be interested in. And so after I knew I wanted to go into medical school, which I realized in high school by volunteering at a hospital, I decided to go into pediatrics because I really loved my rotation in medical school.
What qualities, both academic and not, make for a good pediatric doctor?
Great. So in order to be a good pediatric doctor, you have to be compassionate. Being compassionate is different than being kind. Anybody can be nice, but being compassionate is understanding what someone is going through. And compassion can be done even when you don't have children, or you've never experienced the same situation that your patients have gone through. Just putting yourselves in their shoes and fixing their problems in a way that is catered to their situation. So not every child is going through the exact same thing. For example, with an ear infection, if a child comes in and they're allergic to amoxicillin, you might give them another antibiotic. Well, maybe that antibiotic their parent can't afford. So how are we going to fix it so that we know that they can afford the antibiotic that you're going to prescribe? If they can't afford that antibiotic, they might not be able to come back if this child gets another ear infection. What's a solution to ear infections in general that we could help with? Could we send them to an ear, nose, throat doctor to, put in tubes in their ears to help with the ear infections? Things like that. So thinking forward and thinking, catering your solutions to that person and not just the problem and not just the way you learned it. So being adaptable. Yeah.
What common cases do you treat typically?
Say that again.
What common cases do you treat typically?
What common cases? So ear infections are a big one. Colds, viruses are a big one. You see rashes and stuff like that, but on the day-to-day you see wellness visits. So kids come in with no problems at all, and your job is to check and make sure that they're growing and developing normally. Kids come in with sprains or broken bones, or they burn themselves touching something hot. So minor wound care is an important part of my day. And then a lot of anticipatory guidance and telling people things to watch out for. So they might come in with a little bit of a runny nose, but what if they do develop an ear infection? What are signs of that? When should they come back and see you? Or what if this doesn't get better? What are the things that they should try? Or when should they know to see the hospitalist versus you?
How do you handle parents who may disagree with how you chose to treat your patient?
Can you say that again?
Yes, so it's how do you handle parents who may disagree with how you chose to treat your patient?
Okay. So I think the best thing to do is ask them why they are having a tough time with the therapy options. So, I might tell you my idea of what we should do. And then you as a parent would have to tell me, hey, I don't agree with that. And the biggest thing is to be humble and not be triggered by somebody disagreeing with you. And instead listen and say, okay, what is it that you think that I'm not helping with? Or what could I do better? Or what do you think the issue is that I'm not seeing? And you'll be surprised. Sometimes the answers are very reasonable. For example, I saw a patient who came in for chest pain, and they weren't having any chest pain on the exam. They'd only had it one time, and they couldn't really explain it very well. And I told them to come back if their chest pain came back, because I didn't notice anything on my exam. And the parent said, well, actually, I'm concerned that my child has anemia. I have anemia too. And for me, that makes me really short of breath. So that's really what my concern is. They didn't want to just go home. And so if that person hadn't vocalized that, and if I hadn't listened to them, I wouldn't have gotten a blood test to check for anemia, where I found that they were anemic, severely anemic, and they needed to be on iron supplementation. And I could have totally missed that if I hadn't listened to the parents. So I think whenever someone tells you that they don't agree with you, the best way to treat that is as more information for you to treat them better.
Have you ever come across a child abuse situation? How did you handle that as a doctor?
With what situation?
Child abuse.
Yes. Yes, I see kids with child abuse often. So where I trained at University of Oklahoma, we had the #1 rate of child abuse in the nation. So you see it all the time. the best thing you can do is try to keep the child safe. So immediately starting care, calling the child abuse team, having them go to the emergency room for evaluation, and making sure that treatment is swift, so we can get them taken care of.
What is your favorite thing about your field?
I think my favorite thing is seeing kids all day. You get to interact with them. They're so dynamic and fun. And I think people often underestimate how much they understand and how much they can cooperate and do in doctor's visits. It's like being a detective, because a lot of times they can't say words, but they can tell you a lot with just their body language and with their physical exam. And you can learn a lot through that. It's just so fun.
When seeing a patient, what are some strategies for helping children with disabilities who may have a hard time expressing how they feel?
Say that again. Sorry, I'm having a tough time understanding you.
When seeing a patient, what are some strategies for helping children with disabilities who may have a hard time expressing how they feel?
Great. There are lots of different ways you can do that. So children who do have trouble expressing themselves, there's some electronic devices that can help them communicate. As a pediatrician, my best way of helping them communicate is giving them the time and the space to do that. So I always explain everything that I do before I do it. And I also always give them a lot of time to process the things that I say and respond as best they can. And then I reflect back the things that I see. So, if a child is responding in a certain way, I'll tell the parent, hey, I'm noticing that your child seems to not like that what I just said, or they seem to be shaking their head, they seem to be crying, they seem to be complaining, or they seem to be laughing at what I said. That to me signals that they're sad or happy, or that it hurts, or whatever else. Does that seem right? And that gives the child an opportunity to say yes or no, or for the parent who knows the child to say yes or no. So communication goes beyond the verbal, and it goes to the nonverbal and the physical.
Now that you are in this field, has pediatric exceeded your expectations? Is there something you wish you could change?
So pediatrics has definitely been above and beyond. It's definitely my calling, and I kind of knew that before when I went in, but it's even better now that I'm at the end of all of the studying and everything and finally doing it. I think the only thing, I don't think that there's much that I would change. I think the only thing I would change is access to healthcare. I think it would be great if we could have access for everyone, and that the healthcare disparity. So there's so much inequity in healthcare that is related to our socioeconomic status and our public health policies. And if I could reverse those as best as I could, remove racism from healthcare, those are the things that I would change.
What kind of internship opportunities are ideal for high schoolers who wish to pursue this field?
Yeah, so in high school, there are a lot of things you can do to kind of get here. So one is you could ask your pediatrician if they're willing to let you shadow them. A lot of pediatricians and doctors in general love having students come by and learn from them. The other thing is there are a lot of volunteer opportunities in the community. So you could volunteer at a local clinic. You could volunteer at a hospital. There are a lot of opportunities for high schoolers in the summertime to do things like that. So just kind of doing a quick Google search and looking for opportunities in pediatrics. I bet you'll find your local children's hospital has programs, your local clinics have programs, and at worst case scenario, your family doctor or your pediatrician are probably great resources to help you out too.
How has COVID-19 affected your specialty? Has the amount or type of patients you see on a typical day changed?
Yeah, so COVID-19 is serious, and kids do get it. They don't have as severe of a course. They tend to do better, but I do see a lot of kids in clinic with COVID-19. And the biggest concern is that they could give it to their grandparents or their parents who could get really sick, right? So we definitely talk about COVID-19 pretty much anytime any kid comes in for anything that isn't an obvious broken bone or something non-infectious. Because unfortunately, COVID-19 can present any which way in kids. It could look like allergies. It could look like strep. It could look like pneumonia. So, there's a huge variety of cases. So we always have to talk about it. initially when COVID-19 started, everybody was staying home and trying to stay safe. And so they were avoiding doctor's offices too. So I didn't see a lot of kids, but now it's kind of normalized. People are more comfortable coming in, and we've started doing telemedicine visits. So, we see people on the computer or on our phones to talk about health issues as well. So that has made it a lot easier for people to feel safe while also continuing to get their important wellness visits in. So now I see kind of the normal patient panel.
If you know you're interested in pediatrics, do you still need to do surgical rotations in residency?
Yeah, so once you're in residency, you can rotate with surgeons, but you don't do surgical procedures. There are other procedures that pediatricians can do. For example, gastroenterologists do endoscopies where they take a camera and they look inside your tummy, or pulmonologists also do scopes where they look inside of your lungs. But if you wanted to do something surgical like brain surgery or even belly surgeries like appendix removal and stuff like that, you have to go through surgery and not through pediatrics. There are some things that we do though. So if a kiddo comes in with like a cut on their forehead, we can stitch that up. If they have an abscess or an infection, like a boil on their skin, we can cut it open and drain it. If they're having like a little newborn who's under age 3, or if an older kid who has meningitis, we can do lumbar punctures where we use a needle and get some spinal fluid out from their backs. So there are plenty of procedures that we do, but it's not a surgical specialty.
Have you ever had to involve legal professionals or refer to a therapist or psychiatrist for a teenage patient who may be causing self-harm?
Yeah, so self-harm is pretty common in teenagers, unfortunately. So we often do have to either send them to the emergency room to keep them safe, or call an emergency psychiatric line to discuss with a psychiatrist a plan for next steps to keep them safe. So it is something that we do in terms of like legal involvement, not for self-harm, but for abuse. We do have to involve the police. Any more questions?
I think that's the end of the questions we have so far. So thank you so much, Dr. Sunaina, for joining us today and teaching us about pediatrics. It was a wonderful presentation. For those watching this, the link to the quiz has been posted to our link tree found in our Instagram bio and has also been posted in the chat box. Our Instagram is way_organization, so please make sure to have a look. And within this week, we will also be emailing you your certificates. Thank you again.
Great. Well, thank you so much for watching today, and thank you so much for having me.